Endoscopic microdiscectomy. First, the physician determines the precise location of the injury by utilizing MRI images. The spine is marked at midline and then at 8 to 14 centimeters off midline, which is determined by the spinal level being treated. The iliac crest is marked and an instrument is used under live X-ray to determine the appropriate placement. The skin is anesthetized with local injection and a small needle is introduced into the herniation site. A needle stylet is then removed, and the physician may inject contrast agent with dye to identify the disc under fluoroscopy, and also to dye the herniation for easier identification through the scope. The syringe is removed, and a wire is introduced through the needle. An 8 mm small skin incision is then made. The needle is then removed, leaving the wire in place. A dilator is inserted over the wire to gently dilate the tissue to 7.5 millimeters. At this point, we are ready for a series of 3 color-coded reamers to gradually increase the size of the diameter of the incision, and we do this by introducing one reamer, and then a slightly larger reamer, and then again a slightly larger reamer. This gently and carefully dilates and allows the appropriate amount of access that our physician will need to accurately complete the endoscopic microdiscectomy. While reaming, this oftentimes opens up the foramen. This is referred to as a foraminotomy. This creates more space for the exiting nerve root, which may have become compressed. Now that this is complete, the physician inserts forceps to remove a portion of the herniated disc material that is causing compression on the exiting nerve root. This is a very careful process, and the camera allows our physician to see exactly what amount of herniation he is extracting through the working tube. After the herniation is completely removed, a radiofrequency probe is inserted and activated to shrink the annular fibers and seal the annular defects. Basically, this seals around the edges of the disc where herniation once was. The surgery is now complete, and the scope and working channel is then removed. The skin incision is closed with 1 stitch, and dressing is placed over the surgical site. The patient is then set for recovery.